So welcome to our medical webinar tonight that focuses on your questions answered. And it's about lens surgery, as you all know. And we created this program because we want to give you, no matter where you are in the world, the opportunity to hear the best information on genetic aortic conditions from our professional advisory board and other leading medical experts on these conditions. And so before we get started, I want to introduce you to Michael Weimer, who is our president and CEO.
Thanks, Eileen. Good evening, everybody. We're almost up to 100 people now. We're closing quickly, so it's nice to have so many folks with us. You know, this is the 40th anniversary year of the Marfan Foundation, 2021. So I had looked a little bit. Those of you that have been around a while, that's when Prince Charles married Lady Diana. That's when postage stamps in the US were 18 cents. We had our first female justice on the Supreme Court, you know, and the #1 song was Physical by Olivia Newton. So some history there for you. If you don't know the foundation that well, our first staff member and director, Priscilla Ciccarello, is 5 and still alive. I hear from her, I should say alive and kicking. I hear from her pretty much every week or so, which is absolutely great. And Carolyn Levering, some of you would probably know Carolyn. You know, she keeps an eye on us as well and spending time with her husband, Jim, and their grandkids. We had a COVID webinar last week. It's up now. Eileen can tell you, but we had 715 people register. We had over 300 attend. We've had over 400 viewings, really, really great. I don't know whether there's anybody here from Stickler tonight or involved people. They will be even closer with the foundation this year. And we're going to be, they'll be powered by the Marfan Foundation. We also have the new Loeys-Dietz division. We have the vascular EDS division, and we have the GenTAC Alliance, which is a science arm of the foundation. Watch out for Marfan Awareness Month in February. Eileen tells me it's going to be crazy good. We're also just in the early stages of planning a virtual annual conference. So annual conference will return this year. Unfortunately, we could not be in person in Chicago as we had hoped, but we will be bringing you a virtual event organized by volunteers, for volunteers and patients naturally. So that will probably be, we're kind of guessing late June, early July. It won't be day-long kinds of programming, but it should be great. It should be exciting. And then next July, we're back in Newport Beach. I should say we're in Newport Beach, California. We will be in person for that conference in second week of July. And then the following year, we return to Chicago. And so hopefully in 23, in 2023, we better be in Chicago at this point. Anyhow, it's great to be here. I'm once upon a time the director or the CEO of the National Society to Prevent Blindness. So I'm sure this is going to be great for me as well to catch up with what you're asking and Rachel's answers this evening. So with that, over to the 2 stars of the evening. So Eileen.
Great, thank you so much, Michael. So before we introduce our speaker officially, I just wanted a couple of housekeeping notes. So I see some people had raised their hands. You don't need to raise your hand. Just put your questions in the Q&A box. Please don't put them in the chat box because I will not see them at the right time. And also I am not looking at the questions right now, and I see people are asking questions there. So I think maybe hold your questions until you see if Rachel addresses them during this presentation. Because you guys asked so many questions ahead of time, which was incredible. So she's got a lot to cover here. So anyway, tonight we were fortunate to have an outstanding medical expert from our professional advisory board here, Dr. Rachel Kuchtey. She's an assistant professor at Department of Ophthalmology and Visual Sciences at Vanderbilt University in Nashville. She joined the faculty of the Vanderbilt Eye Institute in 2005 after completing her ophthalmology residency and glaucoma fellowship training at the Cole Eye Institute of the Cleveland Clinic Foundation. She specializes in screening, diagnosis, and management of different forms of glaucoma. In addition to her clinical duties, Dr. Kuchtey is a principal investigator of a glaucoma research laboratory funded by the National Eye Institute, which is a pretty big deal. So I'm going to shut my video, my audio off, and I'm going to hand this over to Rachel to share her slides.
Eileen, it says I cannot start screen share.
I just had it in my screen share, so
Okay.
I think we can do it now.
Let me try again.
Yeah.
Here we go. Can you see the screen?
Yep, you're all set.
Perfect. Yeah. Thanks so much, Eileen and Michael, for giving me this opportunity. As Eileen mentioned, I am one of the members in the Professional Advisory Board. I really have a firsthand experience with the board members and everyone running the board. I have to say, this is my favorite society. I belong to many, many professional societies. This is just outstanding society. Patient participation, and I really, I cannot say good enough about this society. Anyway, so I thought that today we're going to just focus on the lens surgery. I've already read many questions. Somehow Eileen is just right down. So she actually organized those questions in the announcement. So I thought that we're just, going over through those questions. Many of those questions will be answered during my presentation, and some are very specific, and I'm more than happy to answer offline, online, what have you, you feel more comfortable. So let me just read through all those questions so you can think through what you have in mind specifically for yourself or for your loved ones. So those are the questions. Here we go. What is a lens dislocation? Why is it so common in Marfan syndrome? How do I know my lens is dislocated? How do I know if my child's lens is dislocated? How does my eye doctor diagnose lens dislocation? And does that affect the vision? What are the treatments? Should that be removed? Should that be replaced? So those are great questions. Think through what you have specifically for yourself. And let me just go through a few slides. Very simple. I felt that the pictures will tell you a lot to help you to visualize what I really mean and give you some jargons that just really kind of like arm you to be knowledgeable when you go talk to your doctors and use some, ask pointed questions and get the best care possible. So here we go. If you look at, Eileen, can you see my pointer, my mouse?
Yes, I do. Yep, I see it.
Okay, so just look at this the slide. If you just concentrate on the top panel, and this is the cartoon version of the half of the eye. If you think, if you do sagittal dissection, or think of it as like a vertical dissection. So here's the front part of the eye, the very tip of the eye is clear, called the cornea, and that the back part of the eye will be here. If you just look at about a third to 1/2 part of the eye, we call that the anterior segment. Now, if you look at this, the lens is located here. It's like a light green, dark green color. It's behind this yellowish, orangish structure called iris. Iris is kind of like a shutter that can react to the light. When the light goes through, in the bright light, your pupil, actually the iris constrict, your pupil constrict. So the light doesn't, overwhelm you. And the light has to go through the lens and eventually reach the retina, and that's how you see. The lens is truly like old-fashioned. Michael was talking about the history. If some of you guys are old enough, you probably still remember the old-fashioned camera. You truly have this lens. This is just like a sophisticated old-fashioned camera. Now you have the lens. Lens can change the shape, move forward, backward, controlled by the muscle. right here. It's right behind this the iris. It's coded in the same color. That is truly embryonically, they're the same structure from the same origin. The muscle can contract. What does that do? The muscles send out the fibers. Those are called the zonule. They are like ligaments. For the lack of a better analogy, but you can think of this is almost like a muscle, and this is like a joint, if you will. Muscle connected to the ligament. And the ligament, they are like a suspending cables holding the lens in the really up in the air, so to speak. So the stability of the lens, the change of the shape, and how big, how round of the lens is really truly determined by the zonules. The zonules, those cables, they're made of proteins. They are acellular structure, meaning that they don't have any cell. They don't regenerate. They're just matrix proteins. And guess what? One of the major proteins is fibrillin 1. And you guys are too familiar with this gene. When you have the mutation in fibrillin 1, you get Marfan syndrome and other whole host of the conditions. So it shouldn't be a surprise to you. If you have fibrillin 1 mutation, the cables are not going to be stable. If the cables are not stable, the lens can literally just fall to the front or the back or tilt. Okay, I have some slides to show you that can cause trouble as well. Now, if you look at the bottom part, this is just unfussed view, meaning that you literally just look at stare at someone. Okay, if the lens is in the good position, you don't see the lens. You see a dark hole. That's a pupil. That's how the light go through, and the pupil can constrict, can dilate, and that's you just see the clear hole. But if someone's lens is dislocated, here we go. You actually can see those fibers, those suspension cables, and this is actually not Marfan patient. This is not just Marfan patient can get a dislocated lens. This is just happen to be one of the most common diseases I see in my clinic called the pseudoexfoliation patients. Those are the patients that the cables, they're not stable. The lens can get dislocated. So I encounter those patients quite often. We have to deal with those patients' complications related to the dislocated lens. Here's my Marfan patient. And you can see this dark eye individual, the color, this is the, if you still remember that diagram showing here, this is that orange-ish color, that's the iris, okay? Now, you do see the lens, you shouldn't see much, but you can see here, there's a crescent shape, dark hole. That's because the lens is dislocated, it's shifted upward. So that's why you're seeing this hole. This is one eye. His other eye, this is my 16-year-old patient. Look at the other eye. You can see this is much more severe, shifted upward and outward. And now you have two regions the light can go through. In this eye, the light largely still go through the focusing lens, and it just, your brain can ignore this part. A small amount of light goes through here. If this eye, he is really confused. His brain is really confused because light goes through. Look at this lens, literally bisecting the pupil. Okay, you have lens going through here, the light go through here. So you receive multiple images in your brain. It is a problem. Why? I'll show you. I have some slides to show you. Now, so this is a severe dislocated lens. And if I'm gonna go back to this slide, you can see this. This one is a pseudoexfoliation patient. You still can see those cables covered with this material, okay? But you can see the cables. They're just not stable. And look at this Marfan patient. The cables are not even there, okay? So this region, the cable is completely missing. So that's why the lens is dislocated, so severe form. Now, what is a big deal? And I tell my patients that this is we're talking about the lens surgery. lens surgery, if you will, we do the cataract surgery is actually the most commonly performed eye surgery in our field. It's actually very fun surgery. You know, this is a pretty dense cataract. You probably can appreciate this. Again, this is the iris, the color part of the eye. This is a pupil. And you cannot miss this. You don't need to be an eye doctor. You can see this is a rock hard cataract right in the middle. You're not going to be able to see well with the cataract like this. So the way we do it is that here is the cartoon version of the cataract surgery. We make an incision. The incision is so small, it's less than 2 millimeter incision, and that can seal on its own. You don't even need the stitches. You put a probe in the eye. Now, when you go there, and here, remember the 1/3 front part of the eye, and you can see this. You make an opening. The lens is actually a very interesting structure. It's almost like an onion with multiple layers. And just think of next time you peel your onion, cut your onion, look at the outer layer. It's very thin membrane, almost like a transparent. That is the outer layer of the lens. We call it a capsule. So you have to be very delicate. You have to be very careful. You make a small opening right here, and the rest part of the lens capsule or the wrapping paper, the onion, is still there. And you go use this probe, we call it phacoemulsification. You literally break down this rock hard cataract. This is just made of denatured proteins. And you break it down and almost like a whisk your egg, if you will. That's called emulsification, right? You use ultrasound energy, you really break it down. While you're breaking it down, you irrigate, and you aspirate as well. You go, and the lens material just go through the same port and back to another, to basically just goes away. You don't get any souvenir after the cataract surgery. Once this is clean, you try your hardest not to break the capsule, leave the capsule intact. You put artificial lens in the eye. This is another instrument, is this injector, and that can go through the same incision. The lens is very soft. You fold it up, the beautiful lens, piece of plastic, you never reject it. It's called implant, but you never have the rejection problem. So the lens goes through this small incision. Once it gets into this, we call the capsular bag. It's like a bag, right? There's an opening. When it gets in, and you can see this is part, we call that optic. It is 6 millimeter diameter, and that just serves as your natural lens. Has a power. I'll show you how we calculate the power. You put in 20 diopter, 19 diopter, what have you, based on the size of your eyeball. So this helps you to focus the lens. And those two little things, we call that haptic. They're kind of like legs or what have you, they're arms. They can stretch, and they stretch in the perfect position, sit right in the back. Okay, that's how we do the cataract surgery. This is a very simple, it's a truly, less than 10 minutes procedure. You don't need to go to sleep. We talk to the patients at the time of surgery. But as I said, not only you need to preserve this thin paper, this thin capsule, you break it, you're in trouble, you have a complication. You also rely on those cables. Those cables have to be stable, okay? This is quite often, this is a rock hard cataract. You have to use a lot of energy to emulsify the denatured protein. So the harder the cataract is, the more energy you will require. And while you're doing this, just the cables have to do their job, holding the lens capsule in position. If they're broken, they're not stable enough, the whole thing can fall. And that's a totally different situation. Here shows, and you may hear this called the PCIOL, ACIOL, okay? What they stand for is called the posterior chamber intraocular lens versus anterior chamber intraocular lens, PC and AC. What does that mean? This, again, we're still staying in the anterior third, the front, the 1/3 of the eye. We're not even going to the back, okay? This is the anterior segment. The whole thing is called the anterior segment. we're using the iris as a divider, if you will. The front part is called AC, anterior chamber. Right underneath the iris, this part is called the posterior chamber. That's where the lens's physiological position is. That should belong. And if you remove this lens, you better put artificial lens in the same position. So that's how I showed you the cartoon, how we do the cataract surgery. We remove the lens, we put called the PCIOL, posterior chamber, intraocular lens. IOL, just artificial lens. Sometimes you hear your doctors just say, I'm going to have to put artificial lens in your eye. That's called IOL. So IOL goes to the posterior chamber. That's in the physiological position. This one actually shows pretty nicely. You can see those cables, right? And you rely on those stable cables to suspend this capsular bag in the position. This is almost just like in the midair. You do have some fluid here and called vitreous, but this is basically it's empty space. You really just rely on those cables to suspend your capsular bag. If cables are broken, cables are not stable, you cannot put the IOL in the physiological position, which is PC. Now, what can you do? One option is to do the AC IOL. You use the color part of the eye, you use the iris, put right on top of this. This is, again, this en face view. You just stare at someone and you can see this. Now you can see this artificial lens. Different design, I put those two here, just shows you that different lenses are available there. Should, pros and cons of different lenses, that every circumstance is different. Most commonly used is this type of lens. We still use this, we don't do that so often, but this is readily available. So we just put it into the anterior chamber called the AC IOL. Now, again, whatever we do, put into the PC IOL, put into the AC IOL, you want to stay in the anterior segment, your own territory. We call ourselves anterior segment surgeons. And if you have to do the retina surgery, you're posterior segment surgeons. So there's kind of a distinct line, and we do require, you do have to have a specialty training. For instance, I am a glaucoma specialist. My territory belongs to the anterior segment when it comes to the surgery. Anytime, if I need someone to do the retina surgery, I have to get my retina colleagues help out to do the surgery because I just don't have that fellowship training. So that's the part you want to stay in your own territory. Here, that's the schematic of the eye. And this is probably you can see a little bit better because this is the entire eye. And here again, about a third here. This is the front part, that's the anterior segment. We put the lens here, and the entire posterior segment is about a 2/3. We call it, contains the retina. Now, if you somehow, the cables, you break the capsule, sometimes you break, the capsule is broken during the surgery. You can even break the cables, or the cables are just naturally just not stable, such as if you have a Marfan syndrome, you have a metabolic condition, you have a pseudoexfoliation. Those cables are just not sturdy. You somehow have to put the lens. You really want to put the lens in the physiological position rather than into the PCIOL. Someone asked a Yamani technique. That's a little detail. I'm actually very, very impressed that someone gets into that detail, that talking about the specific technique. That is just to put the lens still in the physiological position. How do you do this? Yamani is a specific technique that does require you still have to clean out this part to some extent, not completely. So most of the time, when it comes down to the surgery, that you have to put the lens just rather than just put into the anterior chamber, you have to force the lens to get into the posterior chamber without proper natural cables to support. You probably would need to clean out this vitreous a little bit. And if that's the case, you probably would be better off to have your retina specialist to help you. So even though this part is anterior segment surgeons' territory. Retina people sometimes they get into our territory, help out to put artificial lens in the eye. That's what the Yamani technique is. You can actually, we call it sutureless IOL implantation. You use those two arms, basically stick to the eye wall, and you have the IOL, artificial lens, stay in the position. Or traditionally, we just suture it. We suture the IOL using different sutures to do this. Yamani technique has been out just for what's published in just 2017. So we're talking about just 4 years history, not a lot of long-term follow-up. When the paper was published, they were already, some patients already had the 3-year follow-up. But again, it's not a very long history. So we don't have a long-term data yet. My biggest concern about that is that, yes, it is a very elegant, sophisticated technique. But again, if you are relying on putting the lens, stick that haptic or that little arm to the eye wall has to be stable, right? And most part, if it's say it's a young patient, just from trauma, this lens got dislocated, and the eye wall is still okay. Just lenses, the whole eye is still fine. Yes, that is actually a pretty good, indication that the eye wall is fine. You just stick to it, and the lens is in the physiological position, and voila, you're done, right? But the problem of Marfan patients is that the eye wall is just not so sturdy. Your retina is even thin. For no reason, sometimes you can just get a hole, and you get a hole, get a tear, you get to detach the retina. So, for that I don't have a straightforward answer to the Yamani technique, but I think we should wait and see, simply because we don't have a lot of data and unknown nature of the eye stability of the eye wall. You get a detached retina, and that's whole host of complications you have to deal with, and it requires another surgery, detach the retina surgery. Someone stated that my son had 4 or 5 surgeries, and someone had even had choroidal hemorrhage from the cataract surgery. Those are pretty severe complications just from the cataract surgery or lens extraction surgery. So the more surgery you do, the more likelihood you will damage the drainage canal, which is again located in the front part of the eye. If the drainage canal is damaged, you can get the pressure build up inside the eye. When the pressure builds up, this is a closed container, if you will. And here is the back part of the eye. That's an optic nerve. Optic nerve can be, I don't want to say crushed, but you can just imagine when the pressure is too high, that can directly damage the nerve. When the nerve is damaged, we cannot restore this. We have no way to restore the optic nerve. Someone did ask that if the lens is dislocated, can you just replace it? The answer is no. Once the lens is dislocated, if it affects the vision or the other issues, you have to remove it. You have to replace it. You cannot just, this is like if you will, it's like a ball for proteins. If it's not there in the right position, the proteins can denature pretty quickly. And again, the cables are not stable, so you cannot just replace it, put it back in. You have to use the artificial lens to replace it. That's actually is a lens replacement. You're just using the artificial lens to do so. Now, I think one question has and multiple questions about the eyes are extremely nearsighted. We call that myopia, which is a common complications of a Marfan eyes. Part of it is, again, this is a normal eye, this is a myopic eye, and the eye wall is just not so sturdy, so to speak, tends to stretch, and this is much longer. So when the light goes through from the cornea to the lens, rather than reaching to the retina, and it gets lens in the front of the eye. So that's called a myopia. And Marfan patients can have extreme myopia, and that alone can cause some complications. So one way to do this, to take care of this, and you wear glasses. You put up like a minus lens. Some patients have a -15, -20 lens here. So force the light go to the retina. Someone asked if can I just remove this lens, and that is the idea. Overall, if you look at the whole eyeball, okay, it's about a 60 diameter, 60 diopter. I mean, that's the power we use to have the light focus on the retina. Of those 60 diopter, cornea accounts for about 40, lens accounts for about 20. Just imagine if you are -20, okay? What if I just removed this 20 diopter lens? Maybe it's just right. You can do this. Some people even do this. Some eye surgeons even do this for the patients with just myopia, not necessarily related to Marfan. Those are patients, they have to have a relatively healthy eye. For those patients, even though it's somewhat even out, you remove the lens, theoretically, you don't even need to wear the glasses, contact lenses anymore. We still put the artificial lens in the eye simply because that provides a barrier. You don't want to have a direct communication between the posterior segment and the anterior segment. Sometimes we have to leave this direct communication, but for the most part, you want to have some divider for good reason to maintain the health of your eye. So even though sometimes when we remove this 20 diopter lens, we put 0 diopter artificial lens in the eye, just to use this as a physiological or anatomical blocker to separate those two segments. Lots of questions about astigmatism. This is something that I tell my patients, pretty much everyone has a small amount of astigmatism. Most of the time, your brain can ignore that. You don't even know that. That's just my experience. My patients come in, they tell me, oh, I have bad astigmatism. It's just like, sometimes, most of the time, it's not relevant in terms of how well you can see. But Marfan patients, unfortunately, can get a pretty extreme astigmatism, okay? So this is a normal eye. The light goes through here and focus on the back part of the eye. Astigmatism is just a shape, it's just not normal. So the light gets scattered and you get the different points, focal point, landing on the retina. If that happens, this is what you see. You go to the eye doctor's clinic and you check your eyesight. Rather than this crisp E, the 3 arms or 3 legs, whatever you call that, they're nice and dark. Here you go. And oftentimes they describe that. I can still read that's E. Of course I know that's E, but I see like 2 E's, 5 E's, lots of ghost images. Oftentimes that's an indication you have astigmatism. How do we correct that? Now, as I said, the whole eye is about the 60 diopter, and oftentimes the astigmatism is coming from the cornea, meaning, look at this, this is the normal cornea. It's kind of I call that a circle because this meridian and this meridian, they're exactly the same size. Sometimes you hear this at the basketball versus football analogy. If you have a cornea astigmatism, this meridian is much longer, or vice versa. This is just for illustration. This can be corrected with a contact lens pretty easily. And it's a good option. The contact lenses are made now and more newer technology, and they're more breathable and they're more friendly, so to speak, to the cornea. So this can be easily corrected. This is a different situation. Remember my Marfan patient, this is one eye with a severe astigmatism. Cornea is perfectly fine. It's just like this. You can map this. You can use a sophisticated imaging technique and you can see this. I can measure this. This meridian, they're exactly the same. So he has about 8 diopter astigmatism. has nothing to do with cornea. Cornea is perfectly round, close to perfectly round, okay? A little bit difference you can easily ignore. His problem is this. The light go through here and light go through here. And we call it the lenticular astigmatism. And this is very annoying. It's not just like a fuzzy E. You sometimes you see two images and you get a double vision. And sometimes can be dangerous. You know, you see two cars driving by you. So this one gets to that severe, likely you're gonna have to use the lens surgery to correct this. And if you don't correct it, and I think one of the questions is that, what is the consequence if I don't correct it? And this astigmatism is big enough. Just imagine the other eye is still okay. You see well with the one eye, the other eye, this eye, you just don't see well. You learn, your brain learns how to ignore this. That image is just too fuzzy. I'm gonna ignore that. You ignore that long enough, the eye goes out. That's called the strabismus. Marfan patient already has a relatively higher prevalence of a strabismus than normal population. So if you don't correct this eye eventually will go out and cosmetically just doesn't look good. This is in adult patients. In children, if you don't correct the astigmatism, you get this called amblyopia, which is a layman's term, just lazy eye. This eye sees well. Why do I want to bother with this image? It's just so fuzzy. I don't want to use this. And I'm going to just use this eye. And this eye, if you don't strengthen this at a critical time, first of all, you have to detect it by your pediatric ophthalmologist. If you don't detect this, and the child is not going to tell you, they're just happy go around and they just use this eye, and this eye would just never fully develop. Past a certain period of time, typically, 7, 8, there's just no way to correct it. And this eye will be ever, forever, become lazy, and we just cannot strengthen the eyesight anymore. So those are I think that's all I have. Eileen, I'm gonna stop sharing if that's okay.
That's great.
So I hope that gives you some overview for some specific questions. I'm ready to answer any questions.
That was great. That was really great. I have the list I sent you, and you really went through a lot of things there. What's really striking is that even though the brain, compensates for some of the issues, you just think about long-term and how it affects quality of life, or things that you need to be doing as you're functioning, whether it's reading, watching TV, driving. You want to take care of all those vision problems. So great. Okay, so let's see. Let me go through some of these questions here. Is there a critical acquisition period for visual brain development? If vision isn't corrected as a child, will that affect one's future ability to learn to see correctly? I think you just mentioned that, but I think it's worth.
I just mentioned that. Correct. Yes.
If somebody's child is due for her 7th lens surgery, any advice as to why her lens keeps dislocating?
I think that's a little bit more specific. What I would recommend typically, I'm biased. I'm with Vanderbilt. We have all subspecialties, and my patients oftentimes they're surprised. They say, "Why can't you just do this?" And I like you. You've been taking care of me for a long time. I said, "I'm going to get the best surgeon possible." You would think the eyeball is so small. Everyone has a little bit expertise. So I think that it's very possible that if so many eye surgeries has been done, can be done by the anterior segment surgeon, maybe needs a vitrectomy, the retina surgeon has to come in. And believe it or not, sometimes 3 surgeons go in to do one surgery, cornea specialist, cataract surgeon, and the retina surgeon. We do just surgeries, multiple surgeries in one setting. So depending upon how you count, how many surgeries you have had.
Okay, what about attaching the lens to the sclera? Is that something that you do?
I do. If I don't have to disturb the vitreous, I can feel pretty safe in my own territory in the anterior segment. We do that typically we suture the lens into the scleral wall. It's a complicated surgery, much more complicated than just the plain taking out the cataract, putting our artificial lens in the eye. The techniques and the materials have evolved so much for the past, I want to say just 10 years or so, that all sutures, everything has a shelf life. Granted, artificial lens stays in the eye ever, forever. Okay, there's no shelf life whatsoever, and you don't reject that. But the materials we use to suture the lens to the scleral wall does have the shelf life. And we typically 10 years or so that can break. That may be the reason the previous previous question, just why my child had so many surgeries, the suture can break. And now we have the Gore-Tex suture. It's a lot stronger. Still remains to be seen the long-term data, but typical consensus is that that can last much longer. I don't have any experience with the Yamane technique. That's still relatively new. I know about it. I've seen the surgery online, and I've seen in the conference on. But again, it's a little bit too early at this point. I think you do have to discuss with your eye surgeon. Is it truly is a good indication for me to go through that surgery? You literally just stick the haptic to the eye wall without any sutures. Is it sturdy enough? Later on, would you cause complications? So those are the things you need to have some heart-to-heart discussion with your eye doctor.
Great insights. How common is astigmatism in Loeys-Dietz patients, and what exactly does it do to the eye?
Loeys-Dietz, I've very occasionally you can get a dislocated lens, very occasionally, but it falls in the same category as connective tissue disease. It doesn't have to be just lens. The cornea can be misshaped, and the cornea is actually pretty powerful. As I mentioned, it's about 40 diopter, accounts for majority of the refraction. So the cornea, if it's not in the right shape, you can get a pretty large astigmatism. Can be corrected with the contact lenses. The contact lenses are really good now. My pediatric eye doctors, they would even remove the lens if in the young Marfan kids. And sometimes we leave the patients without lens, without artificial lens. The eye is just too small to properly fit artificial lens because the eye still grow. It's still gonna grow, and that the power will change. The artificial lens power will change. So sometimes we just leave it, we call it aphakia, meaning that there's no lens, no artificial lens or natural lens in the eye. The way to mitigate that is to put a contact lens in the eye. As young as 2 years old, you can wear contact lenses. It's pretty amazing. The kids are resilient. They can tolerate contact lenses very well.
Wow. This is a question I hear every single year. Is it okay for someone with Marfan to have LASIK surgery? I
don't recommend it. Even though you don't have a typical Marfan ocular involvement. I didn't get into that. There are some hallmarks, not necessarily related to specific to Marfan's. Marfan patients can be as high as sometimes 60–70% of patients would have dislocated lens. So almost, everyone knows you get a dislocated lens. Some other conditions, you don't know. And some eye doctors are not even fully aware of this. The cornea is very thin, not 100%, but not uncommon. They have extremely thin cornea. And when you do the LASIK procedure, you literally ablate a layer of the cornea. You don't have enough tissue to begin with. Now you have to ablate a layer. And also, oftentimes, the curvature of the cornea is flatter than average patients. So it's difficult to get it just right, so to speak. LASIK patients, oftentimes the consequences of when you get 20 years old, you get LASIK. It's a great procedure. It lasts for good 30–40 years. But when you're 60, you get dry eye. That's almost inevitable. And Marfan patients already, get higher chance to get a dry eye. So all those things long term, I don't think it's a good option. But again, if your eyes are perfect, you don't have thin cornea, you don't have flat cornea, you don't have dislocated lens, you have very low risk to get a detached retina. Talk to your eye doctor. Maybe you're just so inclined to get rid of your glasses and go through the LASIK procedure.
So your eye doctor can see how thin your cornea is?
You absolutely need to get that measurement in order to calculate how much tissue you need to take out. You have to measure the thickness of the cornea. Very standard, not so sophisticated. It's kind of almost like you go into your eye doctor's office, you get your eyesight checked. You get your thickness of the cornea measured as well.
That's good to know. Okay, so Rosemary says that her son had both his lenses removed and every year his prescription changes. How long will this continue to happen?
Depending upon the age, I have some patients, I put an artificial lens, just routine cataract surgery. Most of the time, it doesn't require change of the glasses. So, they're 75 years old, just had the cataract surgery, that the prescription can be, ever, forever, good enough. You don't need to change. Not uncommon. Some patients, the shape of the eyeballs continue to change, very minute change that can change the power. So the correction of the glasses have to be changed. So I suspect that this kid is still relatively young. So probably there's just I have the patient I just saw yesterday. She's 23. She started out when she was 14 with me, 23 years old. She's still, getting glasses changed almost every year. Still growing. Theoretically, 23, you really shouldn't have any changes anymore, but it's not uncommon. I just saw her yesterday, 3 diopter more, so that's not uncommon.
Okay, so there's a couple of questions in a row here about young children and artificial lenses. So how young can they get replacement lenses? Is it okay to remove the lens and then correct vision with glasses? When should they, how long should they wait to get, replacement lenses?
Yeah, I've seen a couple questions just from the list that you have. Again, that's quite specific. But the overall principle is that young kids, you really have to correct their eyesight. You miss that opportunity, that eye will become lazy. It just will never fully develop. You have to grab that window opportunity. So the lens is dislocated. For instance, that the slide I just showed you has a large amount of astigmatism. You're seeing 2 images. That eye would just give up, and then it will never develop. So you're going to have to remove the lens. You have to correct it somehow. You remove the lens, that's one way to correct it. You're going to have to put, it's 20 diopter lens. You have to correct that. Either you put artificial lens in the eye, you can put it into the anterior chamber called ACIOL. You can suture it. If the kid is too young, 1 year old, 2 year old, that probably is not a good idea to do very sophisticated the lens surgery. You want to do the simple one later on. If you have to do the exchange, we do exchange. You remove the old lens, put a different power lens, still the same style, same, the make, but the power can be changed. Does require another surgery. You want to do everything you can to avoid another surgery. You put a lens in the eye, or you just leave the kid to aphakic, do the contact lenses. As I said, 2-3 years old, they can tolerate the contact lenses very well. Whatever it takes, you need to correct the vision to have that eye, to force that eye to match the other eye to fully develop.
So on the other end, somebody's asking, their son has dislocated lenses and has been corrected around the lens. He uses a prescription with glasses, but mostly uses contacts, but he's 29. So now we're on the other end. Would he be a candidate for intraocular lenses? Would you recommend them? Likely,
he would be a candidate. If you're tired of contact lenses, tired of glasses. I have a case coming up. Actually, it's just she's 26 years old, she's going to med school and she just doesn't want to deal with the contact lenses anymore. Okay, let's go ahead and put an artificial lens in the eye. She had lens removed as a kid, as 2-3 years old, left with aphakia, meaning no artificial lens at all. So it's not too late. At any time, you can put a lens in the eye.
If somebody else asked when is the best time to do the surgery, it sounds
There's no best time. There's really no best time.
Yeah. Yep. Get that. Okay. Okay. If a child has extreme myopia and vision is only about 20/70 with glasses, but lenses are not dislocated, would you recommend the lenses be removed?
For what reason? There's no good reason. If the lens is not, you can argue. I mentioned sometimes we call that clear lens extraction for someone for no reason, just because it's so nearsighted. You remove that lens and you could put the artificial lens with a 0 power or very low power, provided that the divider and that you don't have to wear -20, -15 correction of the glasses. They're very thick glasses, and contact lenses sometimes can be difficult to fit as well. So theoretically, you could consider that. Bear in mind, Marfan patients is not just a lens dislocation. There are other conditions that you can have complications. Detached retina. Sometimes just for no reason you get a detached retina, but oftentimes detached retina is related to the trauma, if you will, surgery's type of trauma. You're disturbing the eye. Anytime you disturb the vitreous in that cavity in the posterior chamber, when the posterior segment, when the vitreous, it can tug and pull, that can drag the retina with it. That the retina is already thin. So anytime you do the surgery, you are disturbing the eye. So you do have a higher risk to get a detached retina. For the patients like, say, the Marfan patients, or just being nearsighted for a variety of reasons, before I offer the cataract surgery, before I take the patient to the operating room, even though I don't anticipate any severe complications, sometimes I have a consultation with my retina guy. That my retina colleagues take a look at the patient. Look, this is a Marfan patient. Retina is so thin, but retina is in the perfect position. I am worried. What if the surgery can cause a trauma that the retina can get detached? My retina people will give me some insight. Yes, this is just too risky. That's prophylactic laser this patient. Tuck the retina in position before you go in to do the cataract surgery. It's not uncommon. So, when in doubt, get another opinion. I always tell my patients 2 heads just work better than 1. They like it. This is something, I do have the luxury to get all the consultations I need.
That's great. This you haven't talked about. Can you speak to the research that is currently being done on analyzing the long-term impact of artificial lens replacement?
I'm not sure specifically what data, as I said, that the artificial lens, you may be talking about a premium artificial lens. I'm just imagining.
Well, what's new? Is there anything new or any new data coming out or any new?
Not necessarily. We do have a premium artificial lens, which is the bifocals to put inside the eye. I typically don't recommend that type of lens to my patients with any other secondary conditions, such as the Marfan conditions, simply because the lens, you do have to sacrifice some quality of the vision. You are getting, just wearing the bifocals, you're trying to get, distance and the near at the same time. It's a difficult task to begin with. We all lose that ability. When you get to 40 years old, you lose that ability called accommodation. So you can put the artificial lens in the eye. So the long-term data is most of the time is pretty good, but we don't have 20-year data. And I've seen some patients already lost, 5 years already lost that ability to fully utilize that bifocal part. And it's not cheap. Insurance doesn't cover that. As an eye surgeon, I will feel bad, you'd have someone paying out of pocket big chunk of money and it doesn't even last for a few years. And the quality of vision can be affected. So I think the best case, for the complicated patients, my philosophy is that the less is more. You want to avoid complicated surgery.
If the lens is completely detached and is floated out of the typical field of vision, is there a risk to leaving the loose lens in the eye, or should that come out?
Yes. If it's still intact, the lens is still wrapped around by that thin membrane called the capsule, you probably will be okay. But it's not an emergency, but typically it's not a good idea. The capsule can break, that the lens material can leak out. It's not days, weeks, months, but typically it's not in the right location. You probably will be better off to remove it.
Okay. Is there any way for the ophthalmologist to see or measure the strength of the cables that you've been showing us tonight?
No way. There are some signs you can tell. That's the best approach is to be aware of it. You have to be your own advocate. Yesterday, I have that patient. She just doesn't have any typical Marfan feature at all. So she walks in just like a typical 26 years old. No, the body lens is exactly just a normal size. So you have to tell your doctor, I got a Marfan syndrome, and you better look at my eyes carefully. The eyes, the cables, the zanu, and how stable they are, and there are ways to tell. There's no way to measure the strength, but there are ways. We're using we call it SLAM. Basically, it's just a very powerful magnifier. We look at the eyes. Two signs you can look for, we call it phacodenesis, iridodenesis. Phacodenesis, meaning that when you have the patient move your eyes quickly, and you actually can, under the microscope, you can see the shimmering of the eye. You can actually see the movement of the lens. And sometimes the lens doesn't move, but the iris can move a little bit as well. So that's a sign that the certain part of the cables are just not stable. So you want to be careful at the time of the surgery. Be prepared.
Okay, great. Okay, there's a couple of things that, a couple of like rumor type things that people have heard. So we wanted to check with you on these things. Can a patient with Marfan detach their retina by rubbing their eye too hard?
Typically, it's not a good idea to rub the eye too hard. I've say that trauma is #1 reason to cause the detached retina. So if you rub too hard, you are disturbing the eye. Typically, you have a threshold, a physiological threshold. When you rub your eye, you have itch, you have the urge to do that. When you satisfy yourself, you will stop doing that. So the trauma is not that hard, but I have some patients go extreme. They cannot even touch their eye. I think those eyes are there for you to use. Just, if you have the itch, go ahead and rub your eye, but don't rub too hard.
Exactly. Okay, someone mentioned on a Marfan Facebook group, it wasn't the Marfan Foundation, but Marfan Facebook group, that you can check retinas with an ultrasound to see how likely they would be to detach during surgery. I'd never heard of this before. Is this something that's commonly done? Or
Ultrasound can be done. We do the ultrasound, and typically it's something is blocking us. We are the eye doctors. So we look at the eyes. We literally see everything in the eye. We see the nerve. We see the blood vessels. We see the retina. Simply because your cornea is clear, your lens is clear, allows us to see everything. But if your cornea is opaque, your lens is cloudy. The slide I just showed, rock hard cataract. We cannot even shine the light to the back part of the eye. I don't know how good the retina is. I have to rely on the ultrasound. I'm not seeing the retina, but I can tell by the ultrasound that the echo, the wavelengths, I can tell if there's a detached retina. There's subtle change, such as just a tear, not detached retina. Ultrasound is not going to tell you this.
Wow. All right, a couple of quality of life questions here about activities. So should patients with dislocated lenses avoid amusement rides such as roller coasters? And what about trampolines?
I don't like the roller coaster, so I would say no to that one. I think probably is not a big concern. You do have, your body has that ability to reestablish the equilibrium. So again, this is a physiological, your body has like a physiological stopper. If you are doing so hard to so traumatized to your eye, your body is not going to withstand that. So I'll say be mindful, but I wanted the patients to enjoy the life. This is something you enjoy to do it.
Exactly. I just want to put a word in for your colleagues in orthopedics and in cardiology, because they talk about things like amusement rides and trampolines. So obviously, if you have Marfan, you may also have orthopedic issues, joint and bones. There might be some issues with dislocations, and also regarding roller coasters, what the cardiologists say is it depends on the intensity of the ride and the intensity of your reaction. Some people can handle roller coasters, some people can't. So got to put those two points out there as well. So, all right, you know what? It's getting late and I see some people are dropping off. So I'm going to, hold on to the rest of these questions. We'll send these to Jan, who's the nurse in our help center, and she will answer them with the help of Rachel if she needs that. And let me just share my screen again here as we get to the end here. So there's Jan. She is the wonderful person on the other end when you submit your questions to marfan.org/ask. She will certainly answer your questions, and she's wonderful. Anybody who gets a chance to talk to her loves Jan, and we definitely want to get all your questions answered. And when there's Michael back. Also, if your kids are having eye surgery or surgery of any type, I want to remind you all of the Sydney Lerman Pediatric Hospitality Program, the Sydney and her sister Carly. Sydney actually, her first foray with Marfan was when she needed a heart transplant, when she came to our conference in St. Louis when she was 2 years old, and she's doing great. Happy to report she's graduating from college, going to her first choice, George Washington University next year. The two girls started this pediatric hospitality program. And so I'll send you the link in this follow-up email. If your kids are having surgery through the Lerman program, we can send you a box of cheer. As you see Kelly on the right here, got a box of cheer when she had her spinal surgery. So eye surgeries too, we're happy to send you some goodwill from the Marfan Foundation, thanks to Sydney and her sister Carly. We have more educational opportunities coming up in the next few weeks. We have our personal perspectives panel, how to maximize your doctor visit, January 28th. We'll hear from members of our community with Marfan, Beds, Lois Dietz, along with Gretchen McCarrick, who's a genetic counselor at Johns Hopkins, to answer your questions and share their experiences and what helps them maximize their doctor visit. We have our surgery series, not eyes, but we're going to talk about all different kinds of aortic surgery and heart surgery. In February as part of Marfan Awareness Month. Those are each week. And again, we'll send you the information, and all the details are at marfan.org. And finally, we have lots of other opportunities for support and connection. We have our virtual support groups. We have our 2021 Walk for Victory season with an exciting new incentive program. And I will give you the heads up that we're debuting a new video tomorrow morning. So you can see all about our incentive program, really special. Obviously, you can connect with us on all our social media as well. So before we end tonight, Rachel, do you have any final words about we have 100 people still on, so any final comments about tonight's webinar and their questions?
One thing I think we touched pretty much everything, but I failed to say that get your eyes checked. I think one question said, how often should I get my eyes checked? I typically, your primary care physician, when you're 60 years old, the primary care physicians send their patients to the eye doctor to get their eye checked. For Marfan patients, the minute you get diagnosed, go to your eye doctors. Have them check. If nothing is going on with your eyes, have your eyes checked on a yearly basis.
Thank you. That's great advice to end on tonight. Michael, any final words?
No, I just thought that was terrific. Rachel, thank you very, very much for spending time with us. It's almost like you get to see the ophthalmologist tonight. I mean, it's really great. Doctor on call at Marfan. And, don't hesitate to reach out to our Help and Resource Center either. But that was just great. Rachel, thank you so much. And Eileen, as typical, you're a great co-host.
Thank you. So just want to let everybody know that we are here for you. And what else can we do for you, really? When you get the email tomorrow or the next day with the link to the recording, feel free to just reply and tell us what other ideas you have. There is going to be a survey link in there, so please fill out the survey. Let us know what you think. And have a great night. Hope to see you at the next webinar. Take care.
Bye-bye,
Thank you
everybody.
so much.